Good morning. Good afternoon. Hello, everyone. I imagine that for those of you who join us regularly on Wednesday, that your minds are primed to hear the soothing duet of Zavin and Steph, who have inspired many, including myself. And I'm already warning the side of your brain that handles disappointment. Hello, I'm really, really sorry. Unfortunately, Zavin and Steph can't be here today. A last minute thing came up. So I'm your substitute to VMR facilitator, which is um, a high honor to step in those massive shoes on Wednesday. I don't think Steph has announced it, by the way, but I'm going to say it publicly. Steph is the new editor for the New England Journal Clinical Images. So that is no small deal. It's massive. I saw her name and I was like, oh my God, it's Stephanie V. Sherman. I know that person. So that's the size of the shoes that we're going to try to fill today. I also owe you another apology because I have to leave in like 30 to 40 minutes to make it to work today. So we can try to replicate a little bit of the Thursday 30-minute VMR format. But as you all know, nothing can happen without you guys participating in the chat and especially presenting a case. So I will open it up to the floor to see if anybody has a case that they can present today. In the meantime, I spot a familiar face that I haven't seen for a long time. The one and only Noah Rosenberg is here. Hello. Good morning.
Hello, everyone. It's been way too long.
How are you?
I'm doing well. I'm on evenings right now, which is wonderful. And so I have a little time in the day. And I'm in my kitchen right now. I'm trying to make a little pasta right now,
Ooh,
taking a little
cool.
time off. So I'm trying to combine CP Solver's wellness with this
Awesome.
wellness.
That sounds amazing. You want to update folks on where you're at in your medical life? I think there are a lot of new people here.
Yeah, I'm an intern at Beth Israel Deaconess Medical Center. Still adjusting. I was on night float for a week, so I'm still adjusting to the normal routine, but loving it here. A lot of learning, a lot of imposter syndrome, but it's going well. Yeah, and if anyone, yeah, I mean, a lot of familiar faces, but looking forward to meeting and chatting with new people as well.
Amazing, Noah. It's so nice to Noah is part of the like OG VMR crew from the very beginning, and actually on his journey to his intern year, did a lot of clinical reasoning stuff with his fellow medical students at NYU, and is now a full-fledged MD taking care of patients by himself. Yes, with some help, a little bit of help though, less and less help over time. Alrighty, y'all. Noah's here on a rare occasion. We have to entertain him. We have to make sure that his pasta and his CP Solver's wellness is in combination. So help us out.
I'll be entertained no matter what.
Awesome. All right, y'all. I'll mute for another 30 seconds to see if anybody has a case, and then we'll jump right in.
Ravi, if no one has a case, I have one of the Human DX backups that I can send to anyone in the audience if they want to present it because I'm describing.
Thoughts, folks? Thank you, Vale, for that very kind offer. Well, all righty. You're a regular now.
I don't know. I'm not prepared again, but I can make it happen if I have 1 minute to catch my notes. Okay.
Do you want to say hi real quick?
Well, hello again. For those who haven't met me yet, my name is Katarina. I've become a regular on VMR this past month.
Yeah.
I'm a third year internal medicine resident in Portugal.
Amazing. Katarina, I'm going to ask you for one favor.
Yeah.
Do you mind just saying what you remember as the chief concern, or just to start, and
Yeah.
we'll move on.
Yeah, it's fever.
Okay, all righty. That's super, super helpful. And thank you again for always jumping in and stepping in. And I cannot wait. Your cases have been absolutely incredible. And I think it's telling that we're starting with a fever. And I think the way to approach fever is to really recognize that it is a remarkable sign. We've developed many a test to help us understand what it is that's going on in our patients, but none rise to the level of specificity of a fever. A fever is basically definitive for inflammation. And inflammation is a problem we practice quite frequently in solving. And as Reza has now repeatedly reminded us, comes down to using the I-MADE mnemonic. I-M-A-D-E. I stands for infection, M for malignancy, A for autoimmune, D for drugs, and E for endocrinopathy. And the fever tells us that we are for sure in the world of inflammation. The only caveat is a small one, and it actually is a caveat that came up on our most recent Patreon episode with Reza, which was an incredible case. It was RLR number 67. I highly recommend it. But most of the time, fever is inflammation. And whenever you're trying to solve inflammation, you have to assume it's infection until proven otherwise. So basically, Katarina said the word fever, and our minds should be gravitating immediately to saying, where is this infection? And in order to solve that, we need to know the 4 W's. Who is the patient? What risk factors do they have for infections, immunocompromising conditions, etc.? What is the clinical syndrome? So the who and the what. An important thing to know is where the patient is, because epidemiology influences many, many things. Exposure to fungus, exposure to TB, exposure to Q fever. And then finally, when. Who, what, where, and when. And so I'll pass the mic to my dear friend, Katarina, to tell us who, what, where, when, and more.
So this was a 40-year-old man who presented to RED complaining of fever for about a week and a half. Okay. He had also, this was daily fever, okay, with a spike in the morning and in the afternoon, end of the afternoon. Also a lot of sweating, especially at night, headaches that accompanied the fever, and myalgias, very intense myalgias. He had been to another doctor who had medicated him symptomatically only with no improvement. And so he went to our ED with these complaints. Okay, nothing else.
Oh my gosh, super, super helpful. So essentially what we're hearing is that this person has a fever that's very prominent and debilitating and only really acute in nature. So about 10 days in nature. Hello. And in terms of understanding the what is the clinical syndrome, there's not much. Why is there not much? It's because the localizing symptoms that we have don't have tremendous localizing value. Most people with a headache don't have a problem in their head. Most people with myalgias don't have a problem in their muscle. So these things don't have tremendous localizing value. So your instinct may be, oh, this person with a headache has an encephalitis or a meningitis or something like that, but the probability of that is very, very low. So what's my piece of advice here? Piece of advice is you have to use the base rate and you have to use the clinical syndrome. So no matter what, when somebody has a fever, you have to think of the 6 most common causes of infection, no matter what they say. That's a respiratory tract infection, a skin and soft tissue infection, a urinary infection, hepatobiliary infection, a GI infection, and bacteremia without a source. You have to think about those no matter what, because patients can have minimal respiratory symptoms, minimal urinary symptoms, so on and so forth. So no matter what, we have to hear about what the x-ray is, what the UA is, what the skin exam is, what the liver enzymes are, if there's any diarrhea. And the last one is the most important one. It's to know if there's bacteremia without a clear source. And bacteremia can come from your usual organisms like staph and strep, or it can come from the world. So tick-borne diseases, fungal diseases, all can get into your blood from the outside. So the immediate questions are, is there an extracranial focus to this disease process? And does that come from one of the 6 most common ones? Or is there actually an environmental exposure such as mosquitoes, ticks, soil, blood transfusion, so on and so forth? And if those don't solve the problem very quickly, we probably have to do an imaging and an LP. So I'll pass the mic to you, Katerina, to tell us more.
Okay, so he was absolutely healthy. He had no diseases. He took no medications. His family history was irrelevant. He was Portuguese, as all my patients, but he hadn't had any recent travel. This was also before the time of COVID. He didn't have any pets, no epidemiological risk factors. He lived in an urban area, no unpasteurized products, so nothing risky. And he reported that the day he started having the fever, this was in July, he'd been swimming in a pool with his friends, but the pool was disinfected. It was a public pool, so it was well taken care of, no fresh water contact. So yeah, that was his social history. He didn't smoke or drink, or he had no drug use. His only sexual contact was with his wife, and he had no allergies. So his temperature when he came into the ED was 39 degrees Celsius. His heart rate was 110. His BP, I think, was 120/70. His respiratory rate was 16, and he was setting at 99% on room air. Even though it was febrile, he looked well. A little diaphoretic, but nothing special. His head and neck exam was absolutely normal. There was no lymphadenopathy. His cardiovascular exam was also normal. So was his pulmonary exam. His abdominal exam, the thing that jumped out to me was that his liver was palpable 5 centimeters under his rib cage, but his liver didn't hurt on palpation, and there was no other abnormalities on his abdominal exam. His neuro exam was also normal, no meningeal signs, and his extremities and his skin were also normal. Yeah.
The astute examiner picks up the diseased liver. Really, really nice. I don't think many people would have picked that up. And whenever you're getting signal towards the liver, we usually get signal towards the liver through the exam, through labs, and through exam and labs. And the truth is, the exam that usually tells us that there's something wrong with the liver is seeing the extrahepatic manifestations of chronic liver disease. So seeing somebody has caput medusa, spider angiomas, jaundice, all are usually markers of chronic liver disease. So here, Katerina, you found something wrong with the liver, but there's nothing to suggest that there's chronic liver disease. No ascites, no caput medusa, no pulmonary erythema, no splenomegaly.
Nothing.
So if this is, yeah, beautiful. So if this is a liver problem, it almost certainly is acute in nature. And whenever you can feel the liver, you have to stop, because you might just be feeling a mass within the liver, which has a very different differential diagnosis. So a mass in the liver may be malignant, or if a patient is febrile, a malignancy complicated by cholangitis, Or if you want to explain the fever and the mass in one full swoop, it might be a liver abscess, an amoebic liver abscess, or an echinococcal cyst that's been super infected. So here it's very key to recognize that the liver itself might not be diffusely big, but there's a focality to the bigness, which to the largeness. But if you're dealing with a diffuse liver problem, all I want to show you is when you're thinking liver plus inflammation, it's actually very humbling. Because when you're thinking liver plus inflammation, you're usually thinking hepatitis A, hepatitis B, so on and so forth. But here is the long list of all the infections that can actually involve the liver. It can be a parenchymal problem, usually viral, but many other diseases can affect the liver. There's an entity called emphysematous hepatitis, which is usually lethal. There's tick-borne diseases that can involve the liver, like rickettsial diseases. There's spirochetal diseases, namely leptospirosis, which is an important consideration here, and granulomatous diseases like TB. Parenchymal involvement can be focal in the form of an abscess. And then don't forget about the plumbing. We have to worry about this person's plumbing. Could they have cholangitis with bacteria? Or do they actually have one of the rare liver flukes that can do this? And then remember that the portal vein can be infected too, less commonly by bacteria, but more commonly in the world by schistosomiasis. So here we have a signal towards the liver, and almost no matter what, we have to think about the hepatitis viruses. But I'd encourage you first to step back and humbly recognize that your liver involvement may be focal, which changes everything. But if it's diffuse, think of all the viral causes, but remember that there are all sorts of non-viral causes like tick-borne diseases, spirochetes, and many others. What the rest of the exam tells us is that the signature of this disease has not risen to the surface. So there's no skin involvement, there's no overt respiratory involvement. So we're zeroing in on the liver as a potential clue, but we have to keep in mind the presence of the headache. That may just be the fact that somebody who's not feeling well has a headache, but that may be a clue that we'll have to go back to. So I think the next key question is, what's the deal with the liver? What are the liver enzymes, and is it diffusely involved or focally involved, to shed light on this case? All right, my friend, back to you.
Okay, so his wild cell blood count was 5 with 75% neutrophils. His hemoglobin was 11.5 and his platelets were 200. His chemistry, so his C-reactive protein was 60. His ESR was 95. His AST was 95. ALT 180. ALK phos 131. And his GGT was 340. His sodium was normal, so was his potassium. His glucose was normal. His creatinine was 0.70 and his BUN was 15. His bilirubin was 0.55 and his albumin was 4 with normal total proteins. And so I'm going to give you more information right now. And that is that we did a CT of his abdomen, and it revealed hepatosplenomegaly. So the liver was 20 centimeters of greatest measurement, and his spleen was 16 centimeters. But there were no space-occupying lesions, and the hepatomegaly was homogeneous. And he had also thrombosis of his inferior and superior mesenteric veins. His X-ray of his chest was normal, his EKG was normal, and so was his UA.
Ooh, wow. A lot of data here, a lot of data. Folks, I hope you're humbled. I'm very, very humbled by this. I think there's a lot to worry about here. When you see that the liver and the spleen are both big, the most common connection is that there's a liver disease causing portal hypertension, causing buildup of water in the spleen, causing splenomegaly. But here, there's no reason to suspect that because there's no evidence of portal hypertension elsewhere. The portal vein isn't dilated, and there's no ascites. So here you're probably having to deal with a different disease involving a disease that goes to the liver and spleen without passive congestion being on account for splenomegaly. When you're worried about febrile splenomegaly, that prioritizes the concern for infectious causes of splenic involvement, which really are one of three types. Either the mononucleosis-like infections like EBV and CMV, which are a prominent consideration here because they also tend to cause hepatitis. Tick-borne diseases, which tend to cause more prominent hematological perturbances than we see in this patient, or granulomatous diseases like brucella, coxiella, histoplasmosis, tuberculosis, which are important considerations here, but weakened by the fact that there's no respiratory focus of infection, because that's where those come from. But more importantly, because those infections tend to be more indolent and less hectic than this person's infection. But there's one thing here was, what about the thrombosis? What about the thrombosis that this person has? It's very concerning that this person has thrombosis for two reasons. One, these are atypical veins, meaning that thrombosis in these sites usually represents an ultra hypercoagulable condition, not just any old hypercoagulable condition. But more morbidly, they may represent septic thrombophlebitis. So remember when we were here, 1 second. Oh, I closed it. I'm sorry. I need another second. I'll open it again. We said liver infection. And then we had the portal, we had these mesenteric veins be thrombosed. So we are now wondering, could this person have pyelitis? Okay. So what are the possibilities here? We need to keep ourselves rooted in the simple stuff. And the simple stuff is this person has a hepatitis virus, an EBV, CMV, with an underlying ultra hypercoagulable condition, which we'll talk about in a second. We need to investigate the endemic tick-borne diseases in Portugal and think about the possibility this person has an exposure to a granulomatous infection. We also need to entertain the possibility that this person has pyelitis, which usually comes from a bowel source. So could this person have a bowel lesion that has led bacteria to seed his veins, compromising them? And in a young person with septic thrombophlebitis of their mesenteric veins, you have to think about a unique bacteria called Fusobacterium. That unfortunately has a predilection to do this. And so the cultures of that will be very important. But at the same time, we have to analyze this case also by the possibility that this person has a super hypercoagulable condition. And those ultra hypercoagulable conditions, most of them tend to leave a signature on the CBC. So what are these things that can cause mesenteric vein thromboses? It's these ones. Myeloproliferative neoplasms, which are usually associated with elevated counts, which he doesn't have, but they can be normal in a fraction of patients. So this we'll have to think about. Does he have a microangiopathic hemolytic anemia like TTP? Probably not. Could he have PNH? We should look for it. Does he have sickle cell disease? Probably not, because his smear wasn't remarkable. But as folks have brought up, does he have APLS, which usually is accompanied by thrombocytopenia, but not always. And there's some other things to think about too. So you have us on the edge of our seats, Katerina, and hopefully your astute mind can guide us to closer and closer to the answer.
Okay, I'm going to throw a lot of information at you right now. So I hope you're ready. And this is the aliquot before the final one. So because we were mostly worried about his liver, we did an hepatic biopsy. And what it showed was granulomatous hepatitis with non-caseating granulomas. And we did a PET scan that only painted the liver diffusely. His blood cultures were sterile, even after incubation for longer periods. So we were less worried about this being an involvement of the blood vessels, and we were more worried about it being the thrombosis being secondary to the hepatitis. Okay, so more exams. His quantiferon TB was positive. His serologies for HIV, HBV, HCV, EBV, CMV were all negative. His serologies for syphilis, leptospira, Coxiella, Brucella, Rickettsia, Borrelia, and Bartonella were all negative as well. His autoimmune panel was negative, including antiphospholipid syndrome and all the autoimmune liver diseases and biliary diseases. And we did duodenal biopsy when we for Whipple's disease, and it was also negative. Yeah. So I think I'm going to pause here.
Oh, this is a remarkable workup by outstanding doctors, truly. Your finding of granulomatous hepatitis is very informative, and I think that shaped your workup. Clearly, you were looking for all the granulomatous diseases that can do it. But at the same time, you kept track of the possibility that this could be an infection exacerbating an underlying hypercoagulable condition with your APLS workup, which was marvelous. So the world of granuloma is a complicated one that focuses on infections, entertains the possibility of some autoimmune diseases, namely sarcoidosis, and humbly recognizes the possibility of an underlying malignancy like lymphoma, specifically a Hodgkin's lymphoma. But also pays a little bit of attention to some rare entities. Those entities are common variable immunodeficiency, or CVID, that can cause a granulomatous hepatitis. Drugs can do it too, and then most importantly, foreign bodies. So here, I think the focus should be on infection for a while, and that infection is tuberculosis, which I learned from Katarina is actually endemic in Portugal. And you say that the patient has a positive quantiferon TB, has granulomatous hepatitis, splenomegaly. The case for TB is very strong, maybe even empirically treating for RIPE while you wait for cultures to come back. If you're entertaining TB and you see that the syndrome of tuberculosis is focused more extrapulmonary, you should think about the possibility of Mycobacterium bovis, which can be acquired through prior BCG vaccination and reactivation, or more commonly through ingestion of contaminated milk or milk products. So that's something to think about too, because it would influence your empiric treatment. M. bovis is the exact same as MTV, but is actually intrinsically resistant to pyrazinamide. So you might have to think about what your therapy looks like. But the thing that throws a wrench in being very confident about TB, in my opinion, is the fact that this person has an associated thrombosis. Now, don't get me wrong, I'm sure that TB can cause people to clot, but it doesn't cause people to clot as much as a notorious granulomatous lymphoma, and that's Hodgkin's lymphoma. And Hodgkin's lymphoma has many, many flavors, but a hectic one is not undescribed. This would be aggressive for Hodgkin's because Hodgkin's usually is a supra-diaphragmatic disease in young people involving the cervical node and mediastinum, and we haven't looked at that yet, but that would be unusual for Hodgkin's to just involve the subdiaphragmatic places. But I'm also a little bit worried about Hodgkin's because this patient has a characteristic fever pattern. If you go back to the HPI, I'll read this out to you. He has recent spikes in the morning and afternoon, and the cyclical nature is evocative of the possibility of what's called Pell-Epstein fever, which is a fever of Hodgkin's lymphoma. So this is terrifying because this could be TB, could be lymphoma, could be sarcoid, or it could be a multitude of these. I just learned of a case of somebody who had scleroderma, pure scleroderma, who 2 years later developed pure lupus. So in medicine, anything is possible, but the focus should be on TB and not missing Hodgkin's lymphoma now until we get more and more data. So what would you do? You would really wait for cultures and empirically treat for right maybe, and hope your pathologist can look very closely for those pesky Reed-Sternberg cells to make sure we don't miss Hodgkin's. All right, my friend, that's what I got. Have I fallen?
Okay, this was what happened to this man. So this workup took a long time. Okay, as you probably imagine, he was admitted for 2 months in our ward, and nothing happened to him. He was always febrile in the morning and in the afternoon, and he lost some weight, but nothing else happened. His liver enzymes worsened in the beginning, but he never had liver failure. His GGT got to 1,000, but it got better on its own, never normalized. And his inflammatory markers also got better, but never normalized. So we had time to investigate what was going on. And our pathologist took a long time with his biopsy. And he specifically said that it didn't look like Hodgkin's lymphoma to him. And the cytometry studies from the hepatic biopsy were also negative for lymphoma. So at this point, we had two things in our hands. We had autoimmune, and sarcoid was our biggest concern. And we had infection on the other hand, intracellular agents and TB or other mycobacteria, typical ones. So we didn't really know what to do, because if we wanted to start immunosuppression on him, his quantiferon TB was positive. So we would have to treat him as if he had latent TB at least. So we conferred with our ID department, and what we proposed to him was, okay, are we absolutely sure this isn't TB? No. Can we only treat him as latent TB and then later have him have a multi-resistant infection? No. So we chose to treat him as if this was TB. And we were expecting him to get better around 2 to 3 weeks later. And we started the therapy with antimicrobacterials in our ward to see what happened. And what happened was that 2 days after starting the therapy, he was afebrile, and his liver panel and inflammatory markers completely normalized 2 days after starting the therapy. So we discharged him and we waited for cultures. And his cultures from his liver, all of them were sterile, including the mycobacterial cultures. So what did this man have? We don't know. And I think this is the greatest teaching point for this case, is that we don't always get to a diagnosis. And this humbled me a lot as a first-year internal medicine resident at the time. This was the most interesting case I had all year, and it was the only case where we didn't find an answer. So I followed him. I still follow him as an outpatient, and he's doing great. This never happened again. So it probably wasn't autoimmune as well. We don't know. It could be. Sarcoid resolves on its own all the time, but it usually comes back. It didn't. So what I think happened was that he had an intracellular infection that responded to rifampin from the antimicrobacterial regimen. And we never found out the answer. So yeah, that's the funny part about this case. No final diagnosis.
Oh, Katerina, I'm so impressed by your wisdom and somebody who's in training right now. It seems so silly to think that you're still training. You're teaching us more than many things that I've learned during my training. And I think presenting a case like this where there is no clear answer is really the epitome of clinical reasoning. And I think the way you let that story unfold and taught us is just absolutely marvelous. And I know everyone in the chat appreciates that. Anytime that there's a granuloma in a case, I think what fundamentally is happening is the body is trying to fight whatever disease process, be it a cancer, be it infection, or be it something we don't know yet, as this happens in sarcoid. And I don't think it's uncommon, except for when it's a cancer, for our body to use that granuloma to finish off the process and actually win and be fine. And so not everyone who anti-therapy died from it. And not, and as you pointed out, most people with sarcoid actually have their own sarcoid. So the story of a granuloma is one in which if there's spontaneous improvement, you know that this is not Hodgkin's for sure. And everything else is either that there was an autoimmune trigger like sarcoid, or that you either successfully treated an infection or he successfully treated an infection. And you'll never ever know. I hope you'll never know, because it means that he's fine and will stay fine. So I'm absolutely humbled, as I always am. And I really, really get very excited when see you and have you present a case to us. So thank you again for all the wisdom you're sharing. And to recap some of your wisdom, I'll pass the mic to Franco.
Hi, it was a great case, and here are the teaching points. So first we started with the chief complaint about fever. So fever most of the time equals inflammation. So it is always helpful to use the mnemonic I made, that it stands by infection, malignancy, autoimmune, drug, and endocrine problems. Then the other key point that we can help us to approach fever is the 4 W's. Who? What is the patient? Is the patient immunodepressed or is not immunodepressed? What is the clinical syndrome that we are facing? Where is the patient has been a lot of has have some exposures, and when is the time of the year, and when is the problem happening? The second teaching point that we can relate is about bacteremia. Bacteremia doesn't always, the etiology doesn't always come from the inside, but we can also think about outside sources like tick-borne diseases. If you find a palpable liver, you need to distinguish if it is a true increase of the liver size or if it is something focal like an abscess. Always look for chronic liver problem and stigmata in order to prioritize your diagnosis. If there is a diffuse liver problem, most of the times it's viral. About hepatosplenomegaly the most common cause would be portal hypertension. Fever plus splenomegaly make you prioritize infections first, viral, tick-borne, and granulomas in the later one. Mesenteric vein thrombosis doesn't it usually points to a hypercoagulable state, and sometimes it is infection. You have to think about sepsis and the etiology of Fusobacterium or autoimmune processes. An ultracoagulable state can make you prioritize about neoplasia, MAHA, APLS, sickle cells, and especially when there are thrombi in not so common veins like the mesenteric ones. About granulomas, always think about sarcoid, infections, tuberculosis, drugs, and foreign bodies. Something that, I am from Peru, and something that we are kind of experts here is about tuberculosis, because we have a high prevalence of that. So there is kind of a association about granulomatosis disease and a dissociation about GGT and alkaline phosphatase. That is something that we saw on the labs. So that's kind of a teaching point when those are dissociated, like a high elevated pattern of GGT without a main elevation of alkaline phosphatase can sometimes be related to granulomatosis disease. That is something I wanted to add.
Absolutely marvelous, my friend. Franco is a teacher in Peru, and you can see that his teaching is actually pretty much global. That was absolutely awesome. Thank you so much for such a great recap of a really, really memorable case. All right, y'all. We'll see you again tomorrow for another round of 30-minute VMR at exactly this time. Well, actually, 10 minutes preceding this time. See you then.